Hey, what's up, YouTube? I'm going to be doing another question set with mix-up questions for board review, and based on your previous feedback, I'm going to be doing it completely unedited because it seemed like you guys enjoyed that last time. And I purposely saved a few questions left. I got 111 questions left, so we can do a couple more of these sessions. One of the things I'm going to try and focus on for this video is I'm really, going to try and avoid reading the whole question like I was in the previous videos. So if you really want to take some time to read the question, feel free to pause it, and then you can read, take your own time to read it. But I'm going to try and just read the bare minimum that I need to in order to get through as many questions as possible. And then also just to practice doing some of these questions without fully reading the question, because a lot of times there's a lot of information that you don't actually need. So let's do part of these 111 questions left. We'll hit continue, and let's just do a 20 question. I'm not sure if I'm going to be able to get through all of them, and we'll see how we do. It's been a couple days since I've done one of these because my internet was down quite a bit recently, but I got that fixed. So here's our first question. Let's get started. A 22-year-old woman is seen for a routine prenatal evaluation. She is 10 weeks pregnant. She's got a hemoglobin level of 6.4, leukocyte 11,500, and platelets of 279. What's the following most appropriate treatment? She does have sickle cell disease. So should she get clopidogrel? Doesn't make any sense. She would need that. Exchange transfusion, hydroxyurea, simple transfusion throughout pregnancy, or expectant care. This is actually a very difficult one because for me, I haven't had that many patients with sickle cell. And then I saw it a lot more on the East Coast when I was in Philadelphia. And then also it's a pregnancy question. So it's how should you manage pregnancy during, or sickle cell disease during pregnancy? Everybody should be on hydroxyurea, but I actually don't remember, it's interfering with some of the hemoglobin synthesis. So I don't know. I don't remember it being a teratogen. A lot of times patients at this low level of hemoglobin, they don't necessarily need one. This is one I actually do not know, so I'm probably just going to guess on this one. Exchange transfusion, simple transfusion, hydroxyurea. I'm going to go with simple transfusion, but I think hydroxyurea or expectant care are also probably likely. So expectant care was correct. So no treatment other than expectant care. Risk of eclampsia is higher in patients with sickle cell disease. No routine interventions have been proven to decrease these complications. There's no clear benefit with either simple or exchange transfusion. Although patients with severe obstetric or fetal complications, those with twins or organ dysfunction, may benefit. Hydroxyurea therapy results in decreased mortality in SCD. However, because it's potential teratogenicity, because the mechanism of action of hydroxyurea, let's take a look, so it inhibits DNA synthesis and things like that. So it's definitely, not going to be safe for a kid. So I can open up Anki real quick, and then, I could make a quick card on this, that simple transfusions are not indicated through pregnancy. Although this is something that somebody like a maternal fetal medicine person is probably going to be seeing rather than internal medicine. A 23-year-old woman is evaluated for depression as she prepares for discharge from hospital to home hospice. Medications are fentanyl, oxycodone, ondansetron, polyethylene glycol, blah, blah, blah. Which of the following is the most appropriate treatment? Citalopram, cognitive behavioral therapy, methylphenidate, or sertraline. So she's got metastatic ovarian cancer. Her life expectancy is measured in weeks. She's hospitalized with volume depletion and intermittently tearful. This one's hard because, almost always the answer is going to be cognitive behavioral therapy. But if you only have a life expectancy of weeks, is that going to really help? But then also, if you only have weeks, is an SSRI going to help? And if an SSRI helps, how are you going to choose between citalopram and sertraline? They're pretty similar in most regards. So I think in this case, we're going to go with cognitive behavioral therapy. And then methylphenidate would be for attention, if somebody needed some more attention. And actually it is methylphenidate. That's very interesting. I actually did not. So we're starting off this set not very well. So as you can see, not every session of questions goes very well. Methylphenidate is a rapid-acting psychostimulant that is well tolerated and effective in this treatment of depression at the end of life. Cognitive behavioral therapy is effective, but it's centered on a multi-week, if not months-long set of interventions. And then regarding Celexa versus citalopram, Celexa seems to be associated with a little bit higher of QT prolongation. So for example, citalopram, you can do escitalopram, which has less QT prolongation. But other than that, sertraline and Celexa to me are fairly equivalent. Okay. So yeah, methylphenidate is a rapid-acting psychostimulant that is well tolerated and can be effective in the treatment of depression. Also improves cancer-associated fatigue. So today I learned. A 50-year-old woman is evaluated in the ED for fever and tenderness at the site of a cat bite on the dorsum of her hand 2 days ago. A plain radiograph of the hand shows no gas, foreign body, or bony involvement. Typically with cat bites, it's going to be a lot deeper than it may seem on superficial inspection. And so usually you're going to need antibiotics for this, and you're going to need like anaerobic coverage and things like that. So in addition to surgical consultation, which of the following antibiotic regimens is most appropriate? So in general, for these kind of like bites and stuff, we're probably going to reach for ampicillin, sulbactam, or Unison. Not so much these other ones, at least to my knowledge. So I'm going to stick with ampicillin, sulbactam, and vancomycin. She works at an animal shelter. She's got MRSA, skin infection, so that's why we're adding the vancomycin. And she's up to date on her vaccinations. There's some purulent discharge. So let's see. So treat infected cat bite with a mix of anaerobic and aerobic coverage. And then, yeah, that makes sense. Cat bites are more likely than dog bites to cause infection because of the cat's sharp, narrow teeth. Pasteurella is the most common bacteria in a cat's mouth. And so IV Zosyn, Unison, imipenem, or meropenem are all indicated. Ceftriaxone and metronidazole would not cause the MRSA, would not cover the MRSA. Cipro and aztreonam would not cover MRSA. Imipenem, no MRSA. So most of them just basically lacked MRSA coverage. A 76-year-old woman is evaluated for worsening fatigue. Hemoglobin is 7.5 and ferritin is 1638. Which of the following is the most appropriate management? Deferserax. So these two are making me think this patient has like hemochromatosis. These are like iron chelators or things like that. Perform therapeutic phlebotomy or withhold transfusion until hemoglobin is 6. Oh, sorry, she's got myelodysplastic syndrome. Yeah, you wouldn't be so anemic with a high ferritin. So myelodysplastic syndrome has required transfusion of 1 to 2 units of blood every 5 to 6 weeks. Abdomen is soft. So she's getting iron overload because of how many transfusions she is requiring. And so you're not going to do a therapeutic phlebotomy on somebody who's anemic from their myelodysplastic syndrome. You're also probably not going to withhold transfusion until hemoglobin is super low. Suxamer and Deferserax are both iron binders, so it's going to help reduce the ferritin. But to be honest, I don't really know the difference between both of them. I was initially thinking Deferserax, and then I was leaning towards Suxamer, but it's definitely one of these two. Maybe just this one, Deferserax. And yeah, we're right. I'm surprised 82% of people get this right, because Suxamer, I believe, Suxamer is used to chelate lead. Okay, so good. Now this one has a bit of a clue in its name, Deferserax, so like decrease the ferritin levels. Secondary iron overload from chronic transfusions could be treated with oral chelation agents. Iron excretion has no regulated mechanism, so you can get secondary organ damage from this. If anemia resolves, you can do phlebotomy. When anemia is ongoing, iron chelation is required, for which deferoxamine. Yes, that's the one that we tend to use. That one sounds a lot more familiar than Deferserax. They're relatively toxic with potential kidney and liver damage. And usually greater than 1,000 is when you should consider indication for therapy. Okay, I think it may be a good time to make a couple of cards. So just really simple cards, to be honest. Is methylphenidate indicated for treatment of depression in comfort care patients? Yes. Rapid onset of action may also improve cancer-related fatigue. SSRIs and CBT take longer to work. I just like to add a lot of extra details in there. And then secondary iron overload generally should be treated when ferritin levels are greater than how much? Greater than 1,000. Using deferoxamine. How do you spell it? I actually forgot. Deferoxamine or deferoxamirox. Note side effect. They do have liver and kidney toxicity. However, iron overload is also known to cause organ damage. Okay. Yeah, so a deferoxamirox is oral, whereas deferoxamine is IV. All right, a 49-year-old man is evaluated in the ED for abdominal pain, vomiting, and nausea after binge drinking. His labs here, he's got a very low bicarb level with an anion gap of 21, based on 137 minus 106. Ethanol level is 10. Glucose, lactate, he's acidemic. He's got a respiratory alkalosis on top of his metabolic acidosis, although it's not compensating. And he's got positive ketones, so he's got like alcoholic ketoacidosis. Thiamine and B complex vitamin are administered. And so he is going to need dextrose. So you always want to give them, it's basically like a starvation ketosis, alcoholic ketoacidosis state. So after you give the thiamine, you can give them dextrose after that. In terms of whether, sodium bicarb is indicated, I don't actually know. With a pH of 7.26, I'm not totally sure. Blood pressure is normal. He's hypovolemic or hypotensive. Otherwise, he seems to be doing okay. I think in general, you would just do normal saline, or even maybe a little bit of dextrose with the normal saline, but I actually don't know this one. So let's see. Okay, yeah, this was a difficult one for a lot of people because I think it would be totally reasonable to honestly do any of these, probably. You want to just fluid resuscitate them rapidly, and then you can give them some sugar back afterwards if you need. But then, I wouldn't fault somebody if they wanted to give him sodium bicarb either. So this is like a kind of in-between answer. The treatment is 5% dextrose in normal saline. Let's see, anion gap of 31, sorry, bad math. And decreased insulin secretion as a result of starvation can cause the anion gap. Treatment with dextrose will increase insulin and decrease glucagon secretion, while saline will repair any volume deficit. The combination will correct ketoacidosis. In patients with alcoholism, thiamine should be administered before any glucose-containing solutions. There's no additional indication for bicarb to treat the ketoacidosis. So it looks like he's already got a metabolic alkalosis based on the delta. Yeah, so to calculate the delta, I usually do the change in the anion gap over the change in the bicarb, right? So a normal anion gap is 12. So if this is 31 minus 12, then that's 19. And then you put the denominator of the change in the bicarb. So a normal bicarb is 24. 24 minus 10 is 14. So 19 over 14 is greater than 1. It's not really a concomitant metabolic alkalosis, although it is slightly higher than expected. Usually you want to see a ratio of greater than 2 to really tell you that there's like a true metabolic alkalosis going on. So here's a good image for you guys that I really like. So the delta is the change in the anion gap over the change in the bicarb. So 31 minus 12 over 24 minus 10. And so you can see he's falling in this range of 1 to 2. So there's not really a concomitant metabolic alkalosis, in my opinion. A hospital system is attempting to reduce the number of hospital-acquired infections, including CODIs, bloodstream infections, C. diff infections, and VAPs. A common possible risk factor appears to be the low rate of hand hygiene documented among hospital staff. One of the following measures is most likely to improve hand hygiene rates. Creating a spaghetti diagram. I've never heard of that, and that doesn't sound very effective to me. Lean model is a way to like reduce waste. I mean, I just think of like lean, you're trying to get rid of waste. Reiterate the importance in an email, that's very ineffective. But this PDSA cycle is a very, very classic component of quality improvement. And so this is going to be one, this lean model, if they were trying to reduce waste somewhere, then that would definitely be the right answer. But in this case, we're going to do the PDSA cycle. Four-step process. Additional PDSA cycles are completed until the desired results are achieved, and this could improve the rates of hand hygiene. Lean model aims to maximize value and minimize waste. And then spaghetti diagrams are shown to display flow, may be useful in identifying areas ripe for increased efficiency, but it will not improve hand hygiene rates. A 50-year-old woman is evaluated for a 4-month history of left flank pain, worsening despite NSAIDs and now requiring opioids, and 8.8 pound weight loss. CT scan shows a 10 centimeter, very large left kidney mass with radiographic features of renal cell carcinoma and a 1.2 centimeter single pulmonary nodule. In this case, usually with really large kidney masses, you just go for like a nephrectomy, you just remove the whole kidney. But in this case, there's concern that there's a possible metastatic lesion. Although a metastatic, and then nivolumab I think is for small cell lung cancer. I'd have to review that. But in this case, if it really metastasized to the lungs, I would kind of expect multiple lungs. So it's possible that this is just like a simple pulmonary nodule. Although to be honest, we're really not going to know, right? But it may be something that they like routinely follow up on imaging. But usually you think of greater than 3 centimeters for a pulmonary nodule that like, okay, this is like very concerning for a malignancy. So 1.2 centimeters, it may just be like an incidental pulmonary nodule. So I'm just going to treat the kidney mass. But I wouldn't be surprised if it was like a PET scan too, to make sure there weren't mets anywhere else. But I actually don't think that's the right answer. I think it's probably going to be a nephrectomy, and that is the right answer. But it is metastatic renal cell cancer. Debulking nephrectomy improves survival in patients diagnosed with metastatic kidney cancer, particularly in those with limited metastatic disease. So let's see. There's no histologic diagnosis of cancer at this point. Debulking nephrectomy has been shown to improve survival. Patients with lung-only metastases. I'm getting a lot of phone calls today. In this patient, nephrectomy would serve 2 purposes. It would confirm the diagnosis and also serve as a treatment for metastatic kidney cancer. Nivolumab is used for treatment of advanced clear cell carcinoma. PET-CT scan shows no role in this case, and external beam radiation does not play any role except for palliative treatment. A 44-year-old woman is evaluated for persistent fatigue, headache, myalgia, and arthralgia. Results of her labs are all normal. Which of the following is most likely diagnosis? Anaplasmosis, babesiosis, late-stage Lyme disease, post-Lyme disease syndrome, Powassan virus infection. So this is going to be a little bit, we'll have to see the rest of the question stem. But early localized Lyme disease was diagnosed 2 months ago after the patient returned from a camping trip in western New Jersey with new symptoms and a skin eruption of erythema migrans. She was treated with a 14-day, erythema migrans is like that bullseye rash that you see associated with Lyme disease. She was treated with a 14-day course of doxy, which is the treatment for Lyme, with resolution of the cutaneous lesions, but continuation of the other symptoms, which are now adversely affecting her work and personal life. Full range of motion, no skin lesions, synovitis, or effusions are noted. So anaplasmosis and babesiosis. Anaplasmosis, they would have given us some history of like some white blood cell problems, usually like a monocytosis, and then they have maybe like thrombocytopenia or something. They get like a bunch of like abnormalities on their CBC. Babesiosis, they would give us that blood smear with the tetrad forms and the ring form in there. And so that's what we would see there. Late stage Lyme disease, this is like if it didn't get treated, and then she would probably be having like arthritis and heart block and like even like meningitis, like weird things like that. And I don't know what Powassan virus infection is, so I'm going to say this is probably just a normal post-Lyme disease syndrome that she's experiencing, just like we see, post-COVID syndromes or long-haul COVID. So patient most likely has post-Lyme disease. It's a poorly understood sequela of Lyme disease, but it slowly improves over 6 months. In a patient who lives here, Anaplasma, Babesia, and Powassan virus are all transmitted by the same tick as Borrelia burgdorferi. Anaplasmosis is treated with doxycycline. Doxycycline usually has fever. Babesiosis usually has a flu-like illness and fever. And hemolytic anemia and late-stage Lyme disease would have like all the arthritis and things like that. And then Powassan disease causes meningoencephalitis. A 39-year-old man is evaluated in the hospital after a motorcycle accident that necessitated ORIF of a femur fracture. He's doing okay. Which of the following is the most appropriate urinary catheter management? Change catheter to an antimicrobial one, initiate prophylactic antibiotics, maintain catheter until a patient is ambulatory, remove catheter, and observe for spontaneous voiding. Like, you don't have to read the rest of it. Like, it's very obvious what the answer is. So, just basically remove the catheters as early as possible. A 64-year-old man is evaluated during a follow-up visit for stable angina. The patient is switched to diltiazem. Which of the following is the most appropriate management of the medication regimen? Decrease renolazine, increase atorvastatin, switch lisinopril to ramipril, or no medication adjustment. Sometimes I try and get a clue of what the question's really asking for, just looking at the questions and the answers. But in this case, it's not really giving me like a sense of what they're trying to ask here. He's taking metoprolol and wishes to discontinue due to side effects. He has normal LVEF. And no heart failure. He has hyperlipidemia, hypertension, CAD. He's on low-dose aspirin, lisinopril, metoprolol, isosorbide, renolazine, and atorvastatin. So I don't see any reason to do any of these. I don't see, like, if he's like no longer having any angina anymore, maybe you could take away the renolazine. There's nothing to indicate that he needs to increase his atorvastatin here. There's nothing to indicate he needs to switch his lisinopril, so no medication adjustment. Oh, decrease renolazine. Renolazine decreases symptoms of angina and modestly increases exercise times in patients with stable angina. It should be used with strong CYP inhibitors, and doses should be reduced when in conjunction with moderate CYP inhibitors such as diltiazem and verapamil. Yeah. So, yeah, that's a very, very specific and nuanced one, because like renolazine is not a very common med that we would see anyways. Even if you're like a cardiologist, I feel like I don't see it that often when we're on the CCU service, for example. So renolazine side effects include QT prolonging. I mean, it doesn't even say what the other side effects are, just QT prolonging. A 36-year-old woman is evaluated for posterior neck pain and stiffness that began 1 week ago. She has a negative Sperling test. So that means like she doesn't have kind of radiculopathy, cervical radiculopathy, where it's like coming out and compressing the nerves coming out. Cervical sprain, myelopathy, whiplash associated, or radiculopathy. But, Sperling test, I don't know how accurate it totally is. So the pain is worse with movement of the head. She has limited range of motion of the neck in all directions. She was associated with doing sit-ups, so she probably sprained it. Pain does not radiate down her arms, which you would see with radiculopathy. Myelopathy, you would see like weakness. And so in this case, and she's got tenderness of the cervical paraspinal muscle. So this is definitely a cervical sprain. So, yeah, myelopathy would have difficulty with fine object manipulation, dexterity and gait abnormalities. Radiculopathy would have Sperling test positive, as well as patient symptoms can be improved by holding the patient's hand on the affected side above the patient's head. Shoulder abduct on the affected above. Huh, okay. And then, radiating arm pain. A 59-year-old woman is evaluated in the hospital for swelling of his left leg. He's got a left femoral vein thrombosis. Which of the following is the most appropriate management? Discontinue low molecular weight heparin and begin argatroban. This is if we think he has HIT. Discontinue and begin unfractionated heparin. This would be very uncommon that this would be the answer because they basically have the same mechanism of action. Insert an IBC filter, probably never going to be the right answer because they're pretty bad in general. They aren't very effective. They can get stuck in there. Clots can still form on those. And then overlap low molecular weight heparin and warfarin for 5 days. I don't think so because he's already gotten a clot while he's on low molecular weight heparin. And warfarin, we don't really like using that much anymore, but you're still going to be not having him therapeutically anticoagulated if he's on low molecular weight heparin. So basically, I just need to confirm that he probably has HIT, right? So he has bilateral PEs. He's got DVT of the right lower extremity. Therapy with low molecular weight heparin was started on day 1. He's got chronic heart failure. Hemoglobin of 12.8. Yeah, and so he's platelets of 78,000 and at admission was 168,000. So obviously we could calculate his 4T score, not on the test, but we could just estimate. But it's timing. So what hospital day is it now? 5 days ago. So timing within the first few days, that's fairly highly suspicious. 50% of the platelet drop is very suspicious as well. The only thing is that he doesn't have a prior history of being exposed to a heparin. And then there's some other T that I don't remember, but yeah, it's definitely HIT. So high probability scores are associated with 50% decrease in platelet count, onset between days 5 and 10, new thrombosis. Oh yeah, new thrombosis, and no other cause of thrombocytopenia. A 65-year-old woman is evaluated during a routine exam. Echo shows EF of 50%. Left ventricle is moderately dilated with the end systolic dimension of 42 millimeters. Myxomatous degeneration of the mitral valve is present with severe regurgitation due to posterior leaflet prolapse. Which of the following is the most appropriate next step in management? Severe regurgitation, and her EF is dropping. Usually with mitral regurgitation, if the EF is dropping below 65% or so is when they usually want to do repair. And so in this case, we're not going to do serial echo evaluations. We're not going to do mitral valve replacement or transcatheter mitral valve repair. I think we tend to go with a surgical mitral valve repair because I think it really hasn't been shown to have equivalent outcomes yet with these less invasive approaches compared to this one. Although it might be transcatheter mitral valve repair, but I'm going to go with surgical. And that's the correct answer, 23%. It's always very satisfying when you get an answer right that very few other people got right. Myxomatous degeneration of the mitral valve is common with 1 to 2% of the general population. In 10% of patients, the valvular lesion can progress, become life-threatening. The only definitive therapy is mitral valve surgery. Options are mitral valve repair, replacement. Repair is generally preferred because it is associated with improved survival. Strongly recommended for primary mitral regurg with EF greater than 30, EF 30 to 60%, and ventricular end diastolic and systolic diameter greater than 40 in patients undergoing another cardiac procedure. Mitral valve repair is also reasonable in asymptomatic patients with new onset AFib or pulmonary hypertension. EF of 60% or less is used in defining left ventricular systolic dysfunction. All right. Okay, a 63-year-old man is evaluated in the ED for progressive dyspnea. An echocardiogram demonstrates sinus tachycardia. Which of the following is most likely responsible for the patient's symptoms? atrial esophageal fistula. This is if he like recently got a catheter ablation. So basically you ablate and then they have AFib or something, right? And then you would do an ablation, but you're burning parts of the heart, and you can actually make a hole that goes into the esophagus, and then they just start like bleeding into the esophagus. This guy's, he's got, low blood pressure. He's got pulsus paradoxus. So, this is like cardiac tamponade already. So, this is basically just asking what the complications of catheter ablation are. And atrioesophageal fistula is definitely one of them, but you would probably be like seeing hematemesis or like melena or like GI bleed or something. Cardiac tamponade, he's got pulsus paradoxus. He's got elevated CVP. Heart sounds are difficult to auscultate. That's Beck's triad. So he's got cardiac tamponade. This is a fairly easy one to get when they give you the finding of pulsus paradoxus. Now, in practice, actually, doing a test for pulsus paradoxus is a little bit more nuanced than that, because then just how seems so easy when you get on a test, but it's actually kind of like a fine nuanced thing that you had to do on an actual patient. It's a little bit more involved. So atrioesophageal fistula would present with neurologic symptoms, actually: fever, chest pain, seizures, TIA, food intake, hematemesis, endocarditis. Patients who develop dyspnea in months to years after AFib may have pulmonary vein stenosis. Intervention is only required in 10% of patients. Hematomas and blah, blah, blah are common, but usually onset within hours after the procedure. A 64-year-old woman is evaluated in the ED 4 hours after the abrupt onset of sharp tearing chest and back pain, so aortic dissection. CT angio shows a descending thoracic aortic aneurysm with a maximal diameter of 6.8 and aortic dissection originating just distal to the left subclavian artery and extending just below the diaphragm. There's no involvement in the renal arteries. This one is a large dissection. A lot of times with like these stable dissections that are going on, I think you really could go with stenting. But in this case, I would probably want to do surgical repair. But the thing is, her blood pressure is 173 and her heart rate is 90. So one of the things that you may want to consider before you do the surgery is to get that down as low as possible. Usually systolic less than 120, heart rate 55 to 60, because I think, if they're asking what the most appropriate initial management is, you could get them to the OR right away, but it'd be nice to get their blood pressure and heart rate controlled before you go. You don't want them having like a blood pressure of 170, heart rate of 90 while you're trying to like dissect the aorta or something. So I'm going to say medical therapy, although I would not be surprised if it's open surgical repair. But yeah, medical therapy. So should be initially treated with medical therapy, including beta blockers, nitroprusside, and opioids. Another really good one to consider here would be something like esmolol, because it's going to both lower the heart rate and also lower the blood pressure. There's some other ones that are good for aortic dissection specifically, but labetalol would be a good one actually to consider, more than esmolol. Esmolol is going to be more rate control. So patients with type A dissection and type B dissection, immediate repair is warranted. Endovascular stenting can be used to treat patients with descending aortic aneurysms. However, there is scant evidence to treat this to treat an actual dissection with this. After medical stabilization, TVAR with stent grafting can be used. Usually this is a diameter greater than 6, rapid growth greater than 5 centimeters a year, or end organ damage has an advantage over a shorter hospital stay and less morbidity. So you would not want to do open surgical repair either because of high rates of morbidity. So really just do medical management. All right. Next question. A 69-year-old man is evaluated in the hospital for 4 episodes of chest pain at rest in the last 24 hours. It's crescendo angina or unstable angina. He's got ST segment depressions in the lateral leads, V4 through V6. Metoprolol, nitrates, clopidogrel, and heparin are initiated. What's the most appropriate management? Nuclear stress testing? No, this guy's already having like an MI right now. CT angiography? No. All of this. These are all things to test, whether this person has actual coronary artery disease or signs of ischemia. But he's got all the risk factors. He's high suspicion already. He's got normal troponin levels, but I think the suspicion is high enough with his history, with his EKG changes. You would just go straight to, this is high suspicion. If you have like moderate suspicion, you can do a stress test, but I think this is high suspicion. Okay. Early invasive strategy. Yeah. And you would look at the TIMI and GRACE score to determine whether this patient should get urgent angiography or not. So TIMI score, early invasive strategy benefits patients with TIMI of 5 to 7 and intermediate scores of 3 to 4. This patient has a TIMI risk score of 5 based on 3 traditional risk factors for CAD, aspirin use in the last week, age older than 65, 2 or more angina episodes, blah, blah, blah. Conan, you are amazing. Thank you so much. Something's better than nothing. I really appreciate it. Thank you for tuning in. A 73-year-old woman is hospitalized for an elevated serum creatinine level that has been unresponsive to fluids. Patient has hemoglobin of 9. Creatinine was 0.7. It's 4.1 now. They've got anti-myeloperoxidase antibodies. So that's going to be P-ANCA or microscopic polyangiitis, I believe. I sometimes get that confused still. Chest radiograph shows diffuse infiltrates at the lung bases, necrotizing and crescentic glomerulonephritis with linear staining for IgG. So she's got RPGN, or rapidly progressive glomerulonephritis. Which of the following is the most appropriate test? Anti-double-stranded DNA, anti-glomerular basement membrane, anti-phospholipid A2, and anti-histone. So this is if we think she has lupus. This is if we think she has not Alport syndrome. It might be Alport syndrome. The fact that there's like linear staining here, I forget, there's Alport syndrome and there's that other one that's like type 4 collagen basement membrane disease. Anti-phospholipase A2 receptor is for membranous nephropathy, which is not what she has. She's got glomerulonephritis. And antihistone is going to be for drug-induced lupus. So we have nothing here to suggest that she has drug-induced lupus, nothing to suggest lupus. She's got lung problems. Like it's not Alport, it's the other one. I forgot the actual name for anti-GBM disease, but most likely it's anti-GBM. It may just be called anti-GBM. I can't remember. So most appropriate test is anti-GBM. Goodpasture. Thank you so much, Fabian. Thank you so much. I could not remember the name for the life of me. Goodpasture disease. So the differential is divided, blah, blah, blah. Let's see. So patients positive anti-myeloperoxidase antibodies predict she'll have post-immune staining on the biopsy, but the linear staining on her biopsy is more consistent with anti-GBM. So this was kind of like a false positive, basically. Therefore, testing with anti-GBM antibodies is required to confirm this diagnosis. 1 in 3 patients with anti-GBM will have positive ANCA serologies, usually MPO or P-ANCA in older assays. Diagnosing anti-GBM antibody disease could affect treatment decisions in this case, particularly whether to pursue plasmapheresis, which is indicated for all cases of anti-GBM antibody disease. For ANCA-associated glomerulonephritis, plasmapheresis is reserved for those with alveolar hemorrhage. All right. Next question. A 57-year-old, thank you again, Fabian, for jogging my memory. A 57-year-old postmenopausal woman is evaluated following the diagnosis of right breast ductal carcinoma in situ after lumpectomy. This is a grade 3 ductal carcinoma in situ spanning 2.5 centimeters with negative margins, which is estrogen receptor positive. Lymph nodes were not sampled. She has received primary breast radiation therapy. Which of the following is the most appropriate to decrease the risk of ipsilateral and contralateral breast cancer? So anastrozole is an aromatase inhibitor, so that's going to help decrease the amount of estrogen. Raloxifene and tamoxifen, so both of those are estrogen antagonists, but raloxifene has the benefit of being an agonist on the bone, so that can help a lot with osteoporosis. The problem with raloxifene is that it's got an increased risk for VTE or clots. So that's one of the downsides. Tamoxifen is going to be an agonist in the uterus. So it's going to increase your risk for endometrial cancer. And then 21 gene recurrence score testing. I don't know what that is. It's possible that might be the right answer, but I've never heard of that. So the question is, should she should get hormonal therapy. Should she also get chemo with it? Grade 3 ductal. I think if there was involvement of the lymph nodes were not sampled. Yeah, this is a random hem-onc question that would be very, very difficult for me to answer. I'm just going to go with the super aggressive approach. We'll see. But yeah, I was thinking anastrozole was definitely a correct answer also. Anastrozole in patients younger than 60 decreases the risk of recurrent ipsilateral and contralateral breast cancer, but does not decrease overall survival. Chemotherapy is not indicated in the treatment of DCIS. Tamoxifen alone is a treatment and could be discussed as an alternative to anastrozole, particularly in patients who wish to avoid potential anastrozole side effects such as arthralgia and decreased bone density. All right, next question. A 44-year-old woman is evaluated for a breast lump she noticed 1 week ago. What's the following appropriate diagnostic test? Breast MRI, core needle biopsy, mammography, and ultrasonography, or ultrasonography. So it's definitely not ultrasonography because that's only for women less than 35 that it's recommended to just start with ultrasonography. Most likely it's going to be diagnostic mammography and ultrasonography. No nipple discharge. She has 2 normal children, no family history of breast cancer, dense tissue bilaterally. A mass is measuring 1.8 centimeters. It's firm and mobile with ill-defined margins. We're going to go mammography and ultrasonography. I don't really see any reason that we would get any of the other stuff here. So a clinical exam alone, let's see. For women age 40 or older, mammography followed by ultrasonography is recommended. For women age 30 to 39, ultrasonography or mammography may be performed first at the discretion of the radiologist or referring clinician. And biopsy is reserved for ultrasound confirmed lesions. Totally makes sense. All right, and last question for this set. A 24-year-old man is evaluated for a 6-week history of severely depressed mood and loss of interest in work, family, and friends. He has never had hallucinations, he takes no medications, and does not use alcohol or recreational drugs. Which of the following is the most likely diagnosis? Bipolar disorder, generalized anxiety disorder, MDD, or schizophrenia? So, major depressive disorder, it needs to be symptoms going on for more than 2 weeks, and you need to have 5 out of the 9 SIGI caps, or whatever, 5 out of the 7. Or is it 4 out of 7? Whatever. She's sleeping more than usual, no energy. He's a burden to his family, thinking about suicide. Had similar symptoms 2 years ago. He remained on this therapy for only 2 weeks because his symptoms rapidly abated and he had a surge of energy. 1 year ago, he had a 4-week period during which he had similar increase in energy level. Yeah, so this is bipolar disorder for sure. All right. So that was a pretty obvious one. Answer sheet. So 80% correct. Not too bad, you guys. All right. I think that's going to be the video. I'm going to actually end the stream here so that the video can be posted, since a lot of people wanted the unedited version of me going through these questions. So hopefully this was helpful for you guys. You can see we started off pretty bad with those 2 wrong answers right off the top of the bat, but otherwise it went pretty well. If you want to review this a little bit more, I encourage you to watch the VOD again, because then you can pause the video in order to read the whole question stem. But this time I was kind of going through it more quickly to show you that a lot of times there's just so much bloat in the question stem, and it bogs you down, it takes up your mental capacity, and then you end up not even realizing what the question, you don't even realize anymore what the question is trying to ask. You just get lost in all the details, right? So really focus on reading the first question, and then reading the first sentence or 2, reading the last sentence or 2, and then trying to look through the answers for clues on what's important. I think that's a really good way to kind of preserve some of your mental energy during the test. And then, obviously I try to skim. For the real test, I'm probably going to skim the whole question stem at some point before I put the answer down. But it's just a really good way to really help you sort through what's important and not important in the question stem. So I highly encourage doing that. And so this stream, I showed you an example of how I would do that. You can see a lot of the questions I didn't read through totally and was able to find out what the answer was regardless. So again, if you wanted to read the full questions, just go back to the VOD. You can pause the video and you can read it. And yeah, we'll do another one of these maybe sometime soon, maybe even today. So thanks again for watching. I'll see you in the next video, and peace.